Thank you for joining us for this video today. I'm Tamron Vivian from Lymphatic Therapy Center, where our mission is to provide evidence-based practice to our patients and to create public awareness of the therapies we offer. We hope you enjoy today's chat with Dr. Nicole Stout. Dr. Stout is a research assistant professor in the Department of Hematology and Oncology at West Virginia University Cancer Institute. Dr. Stout is an internationally recognized expert and leader in the field of cancer rehabilitation and survivorship care. She has given over 300 lectures nationally and internationally. She's authored and co-authored over 60 peer-reviewed and invited publications. Her research publications have been foundational in developing the prospective surveillance model for cancer rehabilitation and survivorship care. So welcome, Dr. Nicole Stout.
Thanks, Tamron. I'm so pleased to be with you, not in person, but over the Zoom video, and mostly because we were talking, it's been 10 years, a little more than that, since I've actually been to the Western Cape region. So it's nice to reconnect. I appreciate the invitation.
Great. Dr. Nicole Stout was actually my lecturer when I studied lymphatics all those years ago. So it is really great to reconnect with you, and hopefully we'll have you back in the Western Cape again soon.
I look forward to it. We will certainly do that.
Good. So Nicole, would you be able to tell us your story and how you became involved in cancer rehabilitation?
It's actually an interesting, I always say I sort of became the expert by default, because there just aren't a lot of people, there weren't a lot of people at the time who were doing work in oncology. So I started my career at the hospital at the University of Penn in Philadelphia, a very large institution, large hospital. Working as a physio, we didn't really have cancer. We didn't have a lymphedema program. It wasn't really even on the radar in rehabilitation. And in the late 90s, we started to develop a cancer program, mostly around lymphedema initially. And, our department was looking at expanding, and it was just an opportunity that was there for me to develop my knowledge and skill in a different area. And, I took that opportunity. I knew nothing about cancer. I knew nothing about lymphedema, except that it was interesting. The more I read, and the more it fostered that interest. So it was a little bit serendipitous that I came into it, because it was an opportunity that was there. And at that time, as I said, there weren't a lot of lymphedema programs. There weren't a lot of cancer rehabilitation programs. So I started down that pathway at an institution with a lot of support. We had a wonderful physician who oversaw the program. We developed and expanded the program across different clinical sites. And the physician that I worked with, she did such a great job of getting buy-in from the oncologists, that we grew the population of patients very quickly. We grew awareness among our oncologists very quickly. And so sort of sprung up a program rather quickly. And so I became immersed in a very short time period in lymphedema and oncology. And so over the course of time, being in that field, which is very specialized, being in an institution like Penn, where you see a large volume of cancer, first of all, but also very unique types of cancer cases, very complicated cases. Also, just never a lot of people doing what we were doing. And so because of that, I also felt very compelled to get the word out in the rehabilitation community, to teach as Tamron, as you alluded to, teaching the lymphedema courses was where I started in teaching, and then progressed into teaching more with cancer rehabilitation. So it was a bit of an unknown. It wasn't here's my goal in 5 years. It just sort of happened. And after a few years there, I had the opportunity then to take a research-focused position with the Department of Defense, the U.S. Department of Defense, and I moved to Washington, D.C., and I worked with the Department of Defense and the National Institutes of Health. and developed the prospective surveillance model clinical trials that we published and have become, so robustly evidence-based now and disseminated so broadly. The idea for early intervention, early detection of conditions like lymphedema, but really all of the cadre of impairments and problems that we see in cancer can benefit from early intervention from a rehab specialist. So that was sort of phase two, chapter 2 of my career, and it helped me develop my skills as a researcher, publishing extensively from those studies, as well as really pushing a bit for the dissemination of the model because it was different in rehab. So it put me in front of policymakers in the US and abroad to describe the model, validate the model, show the value and the effectiveness of it in changing outcomes for individuals with cancer. So, I always say, when you find something you love, pursue it vigorously. And I would say that's kind of what I've done in the course of my career. Once I found that knowledge, the love of the knowledge of oncology, it just became, the focus of where I was going, what I was doing, and it encompassed all aspects of my career: clinical research, teaching and education, as well as the service and leadership roles that I have taken. It's very much been focused on that love of oncology.
Well, thank you. We are certainly grateful that you have found the love of oncology, because we are all looking to you and the research that you're doing as a basis for what we need to be doing. And in South Africa, oncology rehabilitation is really only starting now, and we are finding the various therapists who have sought after international training, and we're trying to come together and create more of a South African-based oncology rehab protocol and programs that we can follow. So we're looking at all of the international research, and yours is definitely something that we follow. So thank you for that passion. And as I mentioned, oncology rehabilitation is really young. It's in its infancy in South Africa. And although we might be doing aspects of it, we certainly aren't specialists specifically with oncology yet, although we're striving to get there. So when we say oncology rehabilitation, can you just walk us through exactly what oncology rehabilitation entails and all of the areas that it covers? Because I think a lot of people think that it's just exercise. So help us out. Let us know exactly what it all is.
Right. Yeah, so that's actually a great question. And there are 2 ways that I frame it when I think about sort of the totality of what oncology rehabilitation is. First of all, I think about the person who needs to function during and after cancer treatments. And when we talk about function, I think of function with a capital F. And so that to me means it isn't just physically functioning, being able to move, being able to, to maintain your strength. So those are the physical aspects. But we also have to think about the functional domains around cognition. There are changes that can occur with cancer treatments that impact memory, concentration, and cognitive function. We also have to think about some of the psychosocial domains of function, an individual's level of distress and anxiety, the psychological factors that impact their ability to function. So I think we have to think very broadly around cancer rehabilitation, because it isn't just exercise and movement. That's part of it. There's an impairment aspect to this that is obviously multi-system, because the side effects of cancer treatment impact physical function, cognitive function, sexual function, the psychosocial domains, as I said. So we really have to think very broadly. It isn't so much an impairment-based focus. So to draw a parallel in rehabilitation, we would think about someone who has progressed osteoarthritis of the knee, who requires a knee replacement, right? Something very, very circumscribed, and we put that individual through a treatment, rehabilitation treatment. Perhaps they need surgery. We help them recover after surgery so that they're physically functioning better. Perhaps a return to work, vocational rehabilitation is a part of that. So with cancer, it's very different because it isn't just a physical restoration. There's so many different levels to think about in those broad domains of function because of the multi-system impact that we see occur. Endocrine system, so we have changes in metabolism, we have endocrine changes, bone changes that can occur. We have cardiovascular changes. So cancer treatments affect the systems broadly. So we have to think about function very broadly. The second way that I break out cancer rehabilitation and think of the broad needs of the patient population is across this long continuum of what is cancer care. All right, so we gave that example of the individual with an orthopedic condition who needs a total knee replacement. They have their surgery. We see them for several weeks after that, and they're done. Cancer treatments occur along a continuum that lasts on average 3 years. So it isn't just one episode of an intervention that needs post-intervention restoration, restorative therapies, or supportive therapies. We're really looking at this long continuum. Throughout the continuum of care, different treatments are introduced: surgery, chemotherapy, immunotherapy, radiation, and even within those, there are different types of chemotherapies that are introduced. Each of those different treatments bring about a different set of side effects that impact all of those systems that we discussed. So really, there's a multifactorial perspective that we have to take with cancer. Multiple systems in the body are affected. The time continuum with which we see cancer treatments occur is protracted. So when we think about that from a rehab perspective, does somebody need rehabilitation? Do they need to come to therapy 2 times a week for the entire continuum of cancer care? No. But we should be very aware that at any point in that continuum, when new treatments are introduced, the side effects will impact multiple systems, and there may be functional decline. In fact, it's quite likely most individuals experience decline. It's not if, for most folks, it's when. So recognizing that rehabilitation can occur at any point on that continuum. Now, most of the time, we see individuals who become more severely impaired or even disabled, and we work with them then to restore function or to provide supportive care services for them. And that right there is a very important starting place for rehabilitation. It's something that if you're starting to do oncology, we're very familiar with this referral-based type of system. We have an individual who has a level of severity of impairment, it's interfering with their function, refer them for rehabilitation services. That's a great starting place. It's familiar to us as rehab providers. It's familiar, hopefully, to our physician colleagues. The exercise piece is critical, and again, throughout the continuum of care, it's critical. The problem that we see, however, is that many times the exercise prescription must change throughout that continuum based on the individual's tolerance level and their side effects. And the impairments many times intercede, and then they require rehab to help to recover the impairment so that they can continue exercise. So, you know, we hear a lot about exercise prescription from a PT perspective and OT perspective, speech therapy perspective. I'm thinking, how do I help them recover from these multi-system impairments so that they can function, the overall functioning of the individual is better. So that can be speech and swallowing therapies, voice restorative therapies for individuals who have head and neck cancers, esophageal cancers. So those are all elements of function as well. So it's more than just the physical activity. There are balance components. There's activities of daily living components. There's cognition and memory and concentration. So, to think about any rehabilitation provider has a role in helping to support cancer rehabilitation. Every patient going through cancer treatment needs something at some point in the continuum. So that's sort of where I would start to frame the discussion around cancer rehabilitation. The large, the capital F, right? The many domains of function that need to be covered, and the fact that that continuum is protracted. And each of those treatments that we introduce bring about different implications for the ability to function. So rehab interceding at any point in that continuum for the multiple body systems, that's a great way to think about and to frame cancer rehabilitation.
That's great. Thank you, Nicole. So that seemed like a lot that needs to be done along that continuum of care. So what can we tell our patients who are asking us or looking for guidance as to who to go to throughout their cancer journey? What professionals should they seek out? We often don't get the guidance and the referrals that we could need. And we've often heard that our patients, maybe they come to us 5 years down the line and they've got a bit of pain. They come to us with swelling and they say, I thought I had to live with this. I thought I was grateful that I had my surgery and that I'm alive, and this is just what I thought I needed to be. So what can we tell our patients out there? Who should they look for to get the best care and the most evidence-based care that they can?
Yeah, you're getting at a really important nuance in this, and that's awareness. The awareness that rehabilitation is beneficial in cancer. For us as rehab providers, when we look across that continuum at all those different treatments and side effects, we say, well, of course, rehabilitation is important. Well, of course, we can help these individuals. But that isn't common knowledge. It isn't also common practice in oncology. So in oncology, they're very focused on disease treatment, appropriately so. The awareness about rehabilitation may not be as robust. So that's a great starting place if we're thinking about how do we build a program. Elevating awareness among your oncologists about the evidence base that supports the rehab interventions. Patients must be aware because they need to understand that they don't have to live. When I started in this field in the 90s and the early 2000s, that we used to say, you've survived cancer, you should be happy to be alive. And, if you have some pain or some swelling, well, just live with that and be satisfied that you lived through cancer. But what we see today, what we know today is that more people will survive their cancer diagnosis today than ever before. They will go on to live the remainder of their lifespan, the majority of them, upwards of 70%, will go beyond 5 years with no evidence of disease, suggesting that they will have a long life outside and after and beyond cancer treatments. So it is our responsibility to make sure that they have good quality of life and can function. The evidence base today is so robust regarding exercise, regarding rehab interventions, that it's almost negligent for us to sort of rely on the fact that the patient survived cancer, they should be happy to be alive. It's almost negligent if we don't introduce these interventions to help to promote optimal function for these folks. So I think building the awareness among our oncology colleagues, building awareness among patients. Patients should be asking for this service. Who's my rehab provider on the cancer team? They meet various members of their cancer team. They have the connection with their doctor to ask the question, who can I be working with about this stiffness in my shoulder, the pain in my neck? the postural, the tightness in my chest, the pain in my pelvic floor, the fact that I'm incontinent, or just even the fact that I leak urine. Who should I be seeing about that? So the patient should ask those questions, but we have to build that awareness in the patient population. So who should the patient be seeing? Ideally, rehabilitation providers have the knowledge and the skills to evaluate these individuals. We understand physical, cognitive impairment. We can identify those impairments and we can treat them. Part of the issue, though, is awareness among our own contingency of rehab providers, right? So I have had therapists in my own profession in PT who have said things like, well, what do we really do for people going through cancer treatment? Shouldn't we just wait until they get done and see how they do? And, they're very sick and they're frail and, we probably shouldn't do too much with them. And that is the wrong answer. The evidence that we have today suggests that intervention throughout the continuum of care helps to mitigate the side effect impact on function. Say, well, I'm going to use ultrasound, but what are the contraindications to ultrasound? Well, you could stand there in your exam and rattle off and say, I don't do ultrasound over a pregnant uterus, don't do it over the eyes, and cancer, don't do it in someone who has cancer. But so we've taught cancer to rehab professionals mostly in the negative. We've taught about all the things not to do, all the contraindications, but what we haven't done well, we're building towards doing better, is teaching rehab providers about how to intervene with our rehab interventions, how to intervene to help to support and restore function in these individuals. Exercise prescription, strength recommendations, balance exercises, what types of tools do we use to measure what types of interventions are most effective. The evidence base has grown so substantially that we're now starting to move in that direction and teaching more broadly. PTs, OTs, speech therapists, vocational rehab, the whole cadre in rehab medicine is learning more about oncology. So that helps us. So there are now, because we've sort of started to develop this baseline knowledge, we're now starting to see more specialization and more expertise. So an individual perhaps has taken lymphedema training, right? That's a great place for us to think about in this discussion. Lymphedema training, however, is one impairment. Lymphedema is one impairment out of all of those things that we talk about across systems, across the continuum. So because someone has lymphedema training, they probably have some better insight to oncology because they're so closely associated. But they may not be an expert in helping you to develop balance strategies or, a program for cognitive rehabilitation or even an exercise program for cancer-related fatigue. So the oncology specialist is more than the lymphedema specialist, although a lymphedema specialist is fantastic. It's a place to start. But I do think we're starting to see a level of education that is elevating the knowledge base towards more oncologic specialization. But I think in the absence of, I think something is better than nothing always. So a rehabilitation professional can really be a very supportive individual, very supportive service to offer to anyone with an oncologic diagnosis at any point, not just during that cancer continuum, but as you said, Tamron, 3 years down the line, 5 years down the line. Because the secret about cancer treatments is, I call them the gift that keeps on giving. Because once an individual is done with cancer treatment, it doesn't mean that cancer treatments are done with them. Many of these folks will experience what we call late effects. So radiation is a great example. They'll have effects from radiation therapy that don't show up until 3, 4, 5 years later. They impact not just the soft tissue, but also other body systems. So finding someone who is a rehab provider who understands the nuances of cancer treatments, the side effects of cancer treatments, that's ideal. But really, any rehabilitation provider can use their knowledge and skills to assess these individuals. They may have to build their knowledge base out to understand the cancer aspects and the side effects and how it impacts function. But I do think that's a good starting place for many.
Great, thank you. And I apologize, I'm having a bit of a storm in my area, so our connection dropped a little bit. But there was one very important point that I wanted to just reiterate that you mentioned, which was I love the saying, living with, through, and beyond cancer. I think one of the things that I hear from our patients is that they are afraid to begin rehabilitation while they're going through their treatments. And I think really once you've got the diagnosis, you're living with cancer, and we can start right from the beginning. Definitely with preparation, education, we can do quite a lot from the very start and while going through the treatment sessions. So
I agree. And I think that, as I said, sometimes that falls by the wayside in the thought process because cancer treatments are intense. And the doctors are very focused on the disease status, but that doesn't mean that we should let everything else fall by the wayside. So the more that the rehab provider can start at the beginning and really walk with the patient through this continuum, to be there to identify when they start to lose ground and then help with interventions, I think that's critical. We've seen an emergence of evidence around prehabilitation. So before they even start treatment, optimizing their function with exercise and rehabilitative interventions before they go into surgery or chemotherapy. So really it is, there is benefit, there are advancements to be seen when we use rehab through the continuum and not just wait until we get done.
Absolutely. And I think with your knowledge and exercise prescription, you'll know that even though you're tired through your treatments, exercise can help with your fatigue management. So it can give you energy and keep you going through that time. So Dr. Nicole.
Oh my goodness. And you know, no, we say that. We say you might feel exhausted and it's counterintuitive to think I should get up and move when I'm so tired, but rest is not best. In fact, getting up and moving helps not just with circulation and endorphin release, but it helps you to build those blood counts back up. So when you're going through chemotherapy and the blood counts drop, that immune suppression is one of the reasons you feel so darn tired. So the exercise can really help to restore that level, increase your energy levels.
And Dr. Stout, what, in your opinion, is the patient's biggest challenge, their biggest barrier to receiving the rehabilitation that they so need?
So big barriers from the patient perspective. I think it's hard. It's incredibly hard for patients when they're going through treatment for us to tell them, you need to come to another appointment. You need to schedule a separate appointment. You need to come to a different location. We're going to put you through an exercise program. We want you to come in X number of times. I think that's very hard for a person going through cancer treatments. And it's one of the reasons in studying rehabilitation models of care, looking at prospective surveillance, we've talked a lot about the idea of the clinically integrated model for rehabilitation in cancer and in oncology. Co-locating the therapy service with the oncology care delivery. And the closer we are to the patient, the more it enables us to assess their function, follow them prospectively, be there as a part of the team, and intervene when necessary. So putting ourselves in proximity to the patient is important. I think a huge challenge for them is, okay, one more visit, one more appointment, a different location. Where am I going to park? What bus is going to get me there? You know, those are very real burdens for individuals going through treatment. So how do we minimize that? The other burden that I think is heavy for individuals is, of course, fear. The fear that as they're going through cancer treatment, the way they feel is diminishing their enthusiasm for participating in work or exercise. But there's also the fear that going to work, exercising, lifting heavy things, gardening, those things could be harmful. And many times, now, anything like that to an excessive degree could be harmful, but this is where the rehab provider can really play an important role. And that's in helping the individual maintain their confidence throughout the duration of treatment, that what they're seeing and experiencing as far as side effects of neuropathy, numbness and tingling in their fingers and feet, balance deficits, those are normal, expected side effects. And there are things that we can do to help you manage those and even overcome them so that the patient feels more confident and more comfortable. You know, you and I in rehabilitation, we know when someone's going through cancer treatments and they come off that chemo cycle and their blood counts are dropping, fatigue levels are at their highest, neuropathy will accumulate in severity for many instances during treatment. But the patient doesn't know that. They're told that, but until they begin to experience it, right? The patient only experiences this once. You and I see thousands of patients, so we understand the trajectory. The patient goes through this once. And so their knowledge, the more that we can educate them, to help them understand, yep, that's how your scar is going to look and going to feel for a period of time. It's going to have this fullness or hardness to it. We're going to help you work through that. The swelling that you have is important. It isn't just going to go away on its own. So again, when we walk with them through the continuum of care, we are, we're not just there for physical support, cognitive support, but we're also there as this sort of emotional support, reinforcing, educating, reminding them that function is important, and kind of giving them license to say, I've had individuals say, I was really thinking about trying to get out and walk 9 holes on the golf course and play. Do you think it's okay for me to do that? Definitely, let's talk about any mobility restrictions that you might have in swinging your club. Let's talk about your level of endurance and fatigue. But I don't ever tell someone, don't do this activity. But as you're going through cancer treatment, it's let's find a way to get you there. But I think without the rehab connection, I feel that burden is heavy for patients, that they are fearful. Well, I probably shouldn't do that because going instead of how can we work with you to help to build you to a point where you can get that built up to participate in that activity.
I really like the way that you explained it, that the patient lives through it once. We've got to maintain our empathy throughout that journey. We might have seen it 100 times, but it's amazing that even though we have, each journey is individual and unique for that patient, but they're feeling it all. They're feeling it all in that one period that they have their cancer journey. So we have so much to learn from our patients. And in South Africa, as I said, we are only starting our oncology rehabilitation journey. So for the therapists and those of us who want to start adding to the pool of research, where do you think we should start? What would be the most valuable for our patients in advancing rehabilitation in South Africa?
So there's almost a benefit to being at the beginning, right? You feel like, well, we're just getting things started. We really don't have a lot. I feel like that's an opportunity to be able to initiate research and build research as you're building your clinical programs. Because we know so much today about the rehab interventions that are effective in different types of cancers. We know so much today about the types of measurement tools that we can use to assess individuals for impairment and functional disability going through cancer treatments. We've characterized populations. We know to a high degree the type of impairment that someone with prostate cancer will experience. We know what someone going through gynecological cancers will experience. So we understand those burden. And so I don't know that you have to focus on studies that repeat all of that, right? So what is important in South Africa? That's number one question, right? I think understanding your patient population there, because it is probably different. So what are some of the unique characteristics in your population? At what stage of disease are individuals commonly diagnosed? What are the most commonly diagnosed cancers within country? And how do those differ from what we see in other areas of the world? There may be differences. So those are important things to look at when you're starting to think about research. What do we see here commonly? The ethnicity and race of your population will be different, obviously, than it is here in the US. And so there may be some genetic tendencies and instances of race and ethnicity that can inform your research questions. And then, of course, there's the socioeconomic and sociodemographic issues and the huge disparities that we see within population. So think about those characteristics of your unique population in South Africa, and incorporate those thoughts into your research questions. So then I think looking at the continuum of care, how is care delivered in South Africa? That may be different. Here in the United States, we take a lot of patients to surgery first, and then we start chemotherapy. And in many other parts of the world, neoadjuvant or chemotherapy up front before surgery is more common in certain types of cancers. So look at the care continuum of how care is commonly delivered. Identify where cancer care is commonly delivered. Is it all in large hospital systems and cancer centers? Who primarily drives the care plan? Is it the surgical oncologist? Is it the medical oncologist? And where might you then begin to intercede with a program intervention or a research questions or a research plan? So I think those are all things to look at and to consider in developing your research program. And then, I think a lot of implementation work needs to be done to identify how early in the cancer care continuum we can get rehabilitation providers interfacing with the patient. And the barriers and facilitators for that will be different in South Africa than they are in other countries. And so although we can share with you what we've learned in the US, our payment schemes here are different, right? Our the drivers and the incentives for treatment are different. And so I think understanding the implementation of rehabilitation is an important research questions to ask. And then, of course, really looking at the level of disability in individuals. If you identify that patients within your country are in a certain type of cancer are identified at very high stages, and we anticipate their treatment interventions to be more intense, does introducing rehab early for those individuals help with returning them to work? Does it help with reducing their level of disability? And does it impact survival outcomes? Those are questions that I think are important for us to think about as well. But if I were, just like I said, you're starting in the beginning. That's an ideal. Is you're building capacity clinically. I would think about how can we integrate some research investigation into building that clinical site and identifying what type of patients we see, what is their level of morbidity when we see them, where are they in the care continuum, and then what did our intervention do to impact those various factors? Did I have to change my intervention because of health literacy or just literacy issues? Did I have to change my intervention because of economic factors and barriers that this patient experienced? Are there alternative methods that I had to use so that the patient could participate? So I think there are a number of opportunities as you're building clinical programs to also integrate and study what you're doing to implement in those programs in oncology rehab.
That's great. Thank you. I'll certainly get my questionnaires ready and send them through for your approval. Sure. You've really given us a lot of information today. And at the same time, you've given us so much rich knowledge, but you've managed to put it in a nutshell so that we can understand exactly what you're saying. So that's really fantastic. Thank you. We have one last question for you, and that is just a fun one, which we'll probably ask all our giants. And we just want to know a little bit about you. And do you prefer mountains or the ocean?
Oh, I'm a mountain girl. Oh my goodness, that's such a great question. I love the outdoors. I like to be outside. I don't like camping though. I don't camp, but I'll spend as much time outdoors, and I really enjoy the mountains because of that. And living here in West Virginia has been absolutely ideal. And you know, I do find that hiking and biking outside, golfing, those are the kinds of activities I find them to be very cathartic for me. It's a therapeutic way for me to, you know, some people enjoy that walk on the beach. For me, it's a walk on a mountain trail or a beautiful view of a mountain sunset or a mountain lake. We enjoy boating. So yeah, those are the things that really get at my heart and reinvigorate me. Mm-hmm.
Fantastic. I'm glad you've got the opportunity to partake in all of those activities. It sounds like fun.
Yeah, and someday when I get back to South Africa, my friend Vonda Parsonage and I are going to play some golf together. She is a big golfer. I see her on Facebook, and I know I'm going to get back there someday, and I'm hopeful to play around with Vonda.
I'm going to message Vonda straight after this.
Yes, do.
Thank you so much, Nicole. And hopefully, if there are lots of questions coming in, maybe sometime we can catch up again in the future.
I would be happy to. If there are questions, you know, certainly you can direct them to me through email. I'm happy to be a resource for you and anyone really as you go forward. As I said, I would I'd love to be able to find a way to come back to Western Cape, whether that's conference, symposium, training, you know, something. Let's, you know, I think there could be opportunities. So
let's make it happen.
Let me be a resource, please.
Great. Do you have any Facebook pages or anything that people could like? Maybe follow your work?
My Facebook page is more like, you know, my personal fun, but that's there. And I am on Twitter. I'm very active on Twitter. And if you have a Twitter account, there really is a pretty robust cancer rehabilitation group and exercise oncology group that engages on Twitter. Very open, very much sharing research, sharing ideas. You know, we have a lot of students who put questions out. So my Twitter handle is at Nicole Stout PT, and you know, follow me, and I'm more than happy to help to get people engaged in the hashtag exercise oncology and the hashtag cancer rehab. Those are two that you can follow and find some really great discussions and some really interesting followers who are real leaders in research in this area.
Fantastic. Well, thank you very much for our time, for your time.
Thank you. It was such a delight to see you again.
And for any of the patients who are wanting to make contact with us, we are based at the Panorama Oncology Center and the Long Beach Medical Center. So you can just give us an email at info@lymphatictherapycenter.com. Thank you, Nicole, and we'll chat soon.